Can everybody hear me okay before I start? I don't really know how to follow, really. I didn't bring any kind of funny...
Just wave your arms.
Just wave my arms, okay, that's absolutely fine. Thank you for the introduction, and that was a great session on human factors. I want to talk to you a little bit around continuous improvement leading to service redesign. It's a community example I'm going to give you at the end. As you can see there, and I've been introduced, you know my name. I'm Senior Health Outcomes Manager at Smith & Nephew. I started in the NHS, I'm a clinician by background, started in 1984, so been around quite a long time in the NHS before coming out into industry. I'm also Senior Lecturer for the Open University, and I still do some bank work in the NHS. So that's a little bit about my background. So I think when we think about value-based partnerships particularly, the kind of the fundamentals of that are all around quality and continuous improvement. If we don't have any data to have a look at, we can't redesign our services. And you can see there on the left-hand side, we're hoping to achieve all of these through continuous improvement projects at any one time. So improved outcomes, that should be a formality in everything, what we want to do and base everything upon. We want to lower cost. We want to look at systematic change and continuous improvement in terms of a forward-thinking, proactive, innovative redesigning of services. I know it's really difficult in the current environment, but we do need to be making sure that we're striving to do that for our patients. And it's all around real-time measurement. So more of that data, we've heard about data this morning, the more we can have that locally, look at our service, find out where the areas are that we can improve, then the better it can be. And really to make that difference, the bottom right-hand side, it's about improving the safety, we've heard about that this morning, the effectiveness and the experience of care by using understanding of our complex healthcare environment, and it is incredibly complex. Our patients are more complex, there's more of our patients, they're living longer, so there's lots of issues there around our patients and the healthcare environment at the moment. But I just want to take you back really a little bit of a timeline and things that I remember around kind of quality improvement as it started. I don't know if any of you were in the NHS in the 1980s, but those that were, don't know if you remember the old time and motion studies that we used to do. I remember as a staff nurse feeling very important with my clipboard and my stopwatch, literally timing everybody within an inch of their life as to what they were doing with their patients. And then as a district nurse, of course, we were logging visit times, and it was very much the starting point of looking at services and how can we change them. Of course, things have improved since then, I'm glad to say. But then in 1998, you can see there, we had the real first publications, I think, that really started to look at high-quality services for all. We had the introduction of NICE, and if you happen to pick up any of the main documents from this around this time, the word quality was used no less than 360 times in some of those major documents, policy documents that were around. So a real drive towards quality, I think. Then if we kind of come forward to 2008, we had the National Clinical Audit, we had HQIP for the first time, and we saw the replacement of the NHS Institute for Innovation and Improvement to NHS Improving Quality 2013. So a real kind of historical look at quality improvement there, which has now become continuous improvement because we love to change the terms an awful lot. But then if we fast forward to the present day, it's not unusual to see a PDSA cycle, so a Plan, Do, Study, Act cycle to be used in the NHS. And of course, quality and improvement are fully embedded in the culture of the NHS as much as we can. And we know there are areas where we need to work on. And I think I kind of remember this because when I first qualified as a nurse in 1987, I was told that I had two jobs to do when I went to work. One was to do the job and get on with it, but also to try and improve it. But I know that improving it it's very, very simplistic, and it's easy to say that, isn't it? I just want to improve the healthcare that I deliver. But how do you do that? We already know we're under-resourced. You know, the NHS doesn't have the resource necessarily to do some of this continuous improvement. There is a lot of staff fatigue. People see it as something that can come back to bite them. You know, are you criticising my care? There's lots of different issues really around how quality improvement programmes kind of need to be looked at in a really sensitive nature, I think. But if we look at the data collection in particular and why these are so important to value-based partnerships, you can see the before there. So we need to have a real understanding of the service. We need to have a real understanding of that patient pathway, which we've heard about again this morning. We need to define the why and the how. So why are we doing it? Are we just doing it because we need to be on a continuous improvement programme and there's pressure coming down from management to make us do that? Or is it actually in the best interest of the service and the patient? We need to do that deeper dive into either a fishbone or a PDSA cycle. Smith and Nephew, we have something called Compass, which is our change management programme, but whichever system or process that you use, it really is important to understand what your service looks like at the very, very beginning. Obviously, baseline data collection and subsequent analysis is really important, and this is where industry can really help work with NHS organisations to really help them understand their services. Then, of course, data collection during and after. Implementation of clinical practice is really, really important. Has the clinical practice change actually made a difference? What is it doing to patient outcomes? And what is it doing to cost ultimately as well? So if we look at services that improve and those that do not, I think a lot of these are very, very self-explanatory, and you'll know all of these anyway. But on the left-hand side, you can see those improved patient outcomes, patient satisfaction, good communication between disciplines, which I think now more than ever is really, really crucial in terms of the complexity of patients. For organisations, so that increase in performance where we are measured in terms of what we are doing, really, really important that services continue to improve to support that system. And then clinician satisfaction and retention. And certainly as a clinician myself, I don't know those of you who are clinicians here today, but knowing that I'm doing a good job in a service that is at its best, if I put my teeth back in, gives me a lot of pride in my work, and I think that really, really does help in today's environment particularly. And then, of course, on the right-hand side, you've got the kind of the negative aspects of that, and the one that I really want to focus on are the disjointed services. I know Jono said this morning that he has a long-term condition. I have a long-term condition as well, so I've got latent autoimmune diabetes, which I'm said makes me very special because I'm kind of a bit of everything all rolled into one. But I find the services quite disjointed for my needs, possibly because it's not a high enough population to get a large investment behind. But it's quite similar in every service that you think of, really. What we don't want are disparities where patients are getting a certain element of care in one part of the UK and then another in another part of the UK. You start to get variations in clinical practice, so patients getting different levels of care in different areas. So really the whole idea is that the service redesigns itself so that we don't get any of those outcomes on the right-hand side that you can see on the slide there. So what do we need for continuous improvement to work? And I think the top quote there kind of says it all, really. Every system is perfectly designed to get the results it achieves. And anybody that works within health, if you kind of think about that on a, just quietly to yourselves, I'm sure everybody can recognise that. I think we need to adopt a continuous improvement model to manage the process. Obviously, we need to answer all those questions that I mentioned before on my previous slide. But I think, do we understand the whole patient pathway? Because sometimes it's not aiming for the stars and redesigning the whole of the service. It can just be one small part of a patient pathway that makes a massive difference to the patient and then subsequently a massive difference to the service. We need to get the right people involved, and by working with a value-based partnership, and I don't know if anyone has got any experience of that, but there is a positive aspect to bringing industry into some of these conversations because they have a network that sits outside the NHS. So we can bring people together, we can bring clinicians, we can bring patients, we can bring other stakeholders together. And I think I mentioned this before, but it's not to be seen as a criticism of current care provision. That's the last thing that we want. And for us as well, and for my experience in continuous improvement, starting small is often the way to go. We want to do everything very, very quickly, but actually if we can do a small quality improvement project in a small area, we can then start to spread out across the system. What we do find, and if anybody is working at a higher level with an ICS or an ICB today, it's really, really difficult to spread good news projects out across the system. So I don't have the answers to that, but if anybody recognises that, maybe there's something that we can all do together to try and help that communication of these projects and the results so that patients do get the benefit across the system and not just in one locality. And then, of course, it's really important to evaluate, redesign, and then test again. So I'm going to talk to you a little bit about wound care. I don't know if anybody knows anything about wound care or if everyone's thinking, oh no, not wounds. I'm not going to show you any gory pictures, I promise. Even though I'd love to because it really floats my boat. But Smith & Nephew is obviously wound care is our business. I'm an ex-tissue viability nurse, so the gorier the better. But I'm not going to take you all through that, you'll be glad to know. But what I am going to do is kind of position wounds. We always talk about wounds, and if you've got experience of wounds, we've spoke about the burden of wounds probably over the last 10 to 15 years. But kind of what I'm proposing is that we talk about it in terms of urgency because it's an urgent situation. You can see there, 2017, 2018, 3.8 million patients with a wound were being treated by the NHS at a cost of £8.3 billion, of which 67% was spent on managing unhealed wounds. So I don't know your level of experience, but maybe you think to yourself a wound is just like a little cut on the back of your hand, you stick a plaster on and it heals and it's all amazing. I'm talking about those kind of venous leg ulcers, surgical incisions that open up and go on to dehiss. I'm talking about kind of those long-standing wounds that are often problematic. And you can see 67% was spent on managing unhealed wounds, as I've just mentioned, but what that means is there's a large cohort of those 3.8 million patients where the wound isn't going anywhere. It's not healing, it's often static, sometimes it's deteriorating. And the impact of that, not only as on a cost implication for the local health economy, but in terms of patient quality of life as well, is really impactful. Because there being 3.8 million patients, and that is growing annually, 7 to 8% annually, it's meant that there was a 71% increase between 2012 to 2017, 2018. And because this is a situation that does not change, so when we look at the data, 1 year isn't necessarily better than another. We see this kind of almost flatline trajectory of patients that just don't go anywhere. They just sit there. I don't know if anybody knows anybody with a wound, but with the amount of patients that we've got with wounds at the moment, it's highly likely that you're going to have one yourself, which is really depressing because having a non-healing wound is pretty awful as a patient. You might have parents that have had a leg ulcer. Somebody somewhere will know somebody who's had a wound, and the kind of impact they have on the patient is pretty impactful, I think. What's really important in terms of community services is that 81% of that total spend is incurred in the community. So it's heavily weighted towards the community. So patients have wounds being seen sometimes 3, 4, 5 times a week by community nurses, their wound not getting any better. And it's a real dire situation. And I think the problem with these patients is that they are completely hidden. They're scattered across the system. Because they often have one or more comorbidities, they're often 65 years and over, so they sit within that ageing population. They often sit in some of those services that you can see on the screen there. It goes unnoticed, it's not physician-led, it's nurse-led, so we don't have that backing necessarily from physicians that you do in other specialities, and it's really about how do we shift the narrative. Obviously, we know we've got an ageing population. It's really important on wound care because approximately 1/3 of all patients with a wound are 65 and over, and that is rising year on year. We collect a considerable amount of data at Smith & Nephew around patients' wounds, the prevalence, what the patient profiling is, and it's going to be a real problem in the future, as is diabetes, coronary heart disease, and the impact that has on wound care. The problem is, and I think it was mentioned this morning on one of the presentations, is that people are living longer, but they're not living longer any healthier. So they're often sicker, they have poorer outcomes anyway. And you can see on the left-hand side there the implications for this often with a patient with a wound. There's an increased workforce resource because the more of these unhealed wounds there are, the more resource that takes to manage them in the community. We have increased costs. We have increased likelihood of hospital admission, really crucial at the moment when we're trying to keep patients at home and not admit them. These patients often have an infection, often a recurrent infection, and then that impacts on our antimicrobial stewardship policies. You often see an increased polypharmacy, so these patients are having multiple drug therapies, often due to the chronic conditions they're presenting with, but then they might have 1, 2, 3, 4 different dressings. So it's a big impact, and it's really heavy on community resource, and of course the reduced quality of life, which I mentioned before. So why the need for value-based healthcare programs? I think we've spoken about this, but it is an uphill battle, and when I go back to work in the NHS, it feels like a constant uphill battle. It's really difficult in maintaining that resource with the diminishing budget that you've often got accompanying that. But when we look at focusing on patient outcomes, it's really about effectiveness. Those long-term partnerships can really develop some great networking opportunities both with industry, and it does foster collaboration and innovation, certainly as I've seen through my role now, but also my role in the NHS. Evidence-based decision-making is absolutely key, and alignment with NHS priorities. So if anything that we do doesn't align with that, then we're not going to get very far. But it's all about improving patient access, reducing those health inequalities that we've heard about before, and enhancing the sustainability of healthcare services. So what does this mean at local community level? Obviously, there needs to be some kind of audit provision. We need to have a look at those budgets and what is actually happening with these wound patients. There's simple clinical interventions, and that is key. If we're going to change anything clinically, the more simple it can be, the better. The less education you need, the less resource. We don't want to be adding additional pressure to that service. And then improve patient outcomes, budget optimisation, and the reduced workload of staff. And it's all around identifying those variations in practice and reducing them as much as we can. So the challenge for frontline community services then, obviously those non-healing wounds that I mentioned are extremely costly to manage, and the number is increasing. For me, it's about that early identification, so it's almost a preventative strategy that we need, looking to expedite healing. We need to improve outcomes for the patient, not only for their quality of life, but for their physical improvement as well. And we need to look at different wound management approaches that help to free up nursing resource so that community nurses have more time to do with the time that they have, perhaps with end-of-life patients or additional patients that come onto the workload. So if we have a look at one example of a long-standing value-based partnership, we carry out at Smith & Nephew quite a lot of in-service evaluations where clinicians have a cohort of patients that are not healing in terms of their wound care. They've had exposure to lots of different treatment options but want to focus in on a particular treatment. And for this example, we're looking at PICO, which is a negative pressure wound therapy that helps non-healing wounds get back into a healing trajectory. You can see there were 17 sites. It was conducted over a 6-year period, and we looked at the study period of 12 weeks. So looking at when the wounds healed, what they did in that 12-week period, and how they responded to PICO. The methodology was around set wound criteria. Obviously, we needed to make sure that it was fit for purpose. We devised a bespoke pre, during and after data collection tool, and then we introduced a simple, that's a simple and a clinical put together, simple clinical intervention with a change in product. So it's just a change in product, which they were already using anyway for different kinds of patients. So they already knew there was no education needed. But what we did was we utilised a validated clinical pathway. And we had, as part of this study, 300, we don't know who it is. Should I sing to it? That would be fun. 323 patients, and they all had non-healing wounds, and they were all included in this data set. So some of the baseline wound characteristics then, remember I said before that some of these wounds, they're either static, deteriorating, or they have delayed healing. All of the wounds included in the study had those characteristics. But you can see there, just want to highlight a couple of things. The circle kind of data on your the left-hand side of the screen, the pink portion, is open surgical wounds. So these are wounds where patients have gone into hospital, they've had an operation, they've come home, and that incision line has broken down for whatever reason. Quite a high percentage of the total population there that we looked at, and that's important when we come back later to have a look at some of the healing rates. Wound duration for the population had an average of 26.5 weeks. That's a long time to have a wound, but I don't know if it surprises you that 23.4% had a wound that was over 12 months. It's not unusual to have a venous leg ulcer for 5, 10, 15 years. Long time for a patient to have a wound. Then if we look at some of the healing outcomes for this particular study, so more than half of the 323 non-healing wounds were healed by the end of the 12-week study. Now, you might think, well, that's only 52%, it's not very impactful, but remember that a lot of these wounds had no healing rate. They'd been around for a long time already, often 6 months plus. We had some that were more than 12 months. So that is a really impressive wound healing statistic that came out of the study. Remember I said about surgical wounds. So surgical wounds were the most likely wound type to heal in the 12-week study period. So if we can try and tackle even the surgical wound population, as that wound dehisces and then becomes a problem for the community, what often happens is, if you can't manage it into the community, they go straight back into hospital. So it's that impact and that burden on acute services that we could try and tackle with that particular it's really strange. Oh, it's fine. Oh, it's okay then. I'm nearly finished, so it's fine. And then, as long as somebody's not prompting me to do a dance song. Oh, we left it in. No, it's fine. I've nearly finished. It's okay. And then, of course, because it's a value-based partnership, I do want to just show you the impact on cost and nursing time. I talked about the nursing resource. And for these patients, the estimated total cost saving was $651 per patient, which then if you apply that to the 323, you can see the difference. And this is quite a small cohort of patients. Across an ICB, the biggest data set that we've got is kind of in the northeast, and they run at about 1,300 wounds at any one time. So you can see if we can just take a portion of those and get these wounds healing, the kind of impact that you'd have on your spend. And of course there, the nursing hours, 4,792 nursing hours were released, equivalent to 28.5 weeks. So some really considerable savings for something that's really simple, that didn't disrupt the service, that actually changed within a 12-week period. So here I'm just trying to emphasize the value, I guess, of some of these partnerships that you can have between industry and the NHS. And then my final thoughts, I think the value-based programs that I've talked about, they can be pivotal in helping redesign services based on continuous improvement methodology. It's not a destination, but it's a journey. So it's not something that we just do as a one-off. We try and do it. It needs to be a certain mindset. That means that it's a cultural change often that we've heard about, and that strive for excellence at every level, whether you be the most senior or the most junior. And when executed correctly as part of long-term plans, the system will reap the benefits, and the example that I've given you today hopefully has given you a little bit of a taste of that. I'm just going to leave that on the screen, but that's everything from me, and thank you for your time today.